Friends, in this video I am going to narrate a small incision cataract surgery. This is the cataract. First, the eyeball is turned down with the help of a muscle hook, and with the help of this forceps, the superior rectus tendon is got hold of, and a superior rectus bridle suture is applied. For surgeons who are going to learn SICS, this suture helps a lot. It keeps the eyeball stable while you make tunnel, and it helps a lot during delivery of the nucleus. Now let us go to a little higher magnification, and now conjunctival peritomy is done for about 2.5 clock hours. Though it is small incision cataract surgery, but in this case the size of the wound is going to be about 7 millimeter. This is a surgery for beginner surgeons, and I don't want to show how we can do SICS with 3.5 millimeter wound. This is a peritomy of about 7 millimeter, and Whitefield cautery is done to stop bleeding, and it helps a lot during making the sclerocorneal tunnel. Very mild cautery is done, and now watch the incision. This is a 15 number PP blade, and this is the incision. Mild frown incision, not a steep frown incision, very mild frown incision, almost straight. Depth of this incision is about 1/3 to half thickness of the sclera. And now sclerocorneal tunnel is being made with the help of this crescent plate. At this time we must keep in mind the contour, the curvature of the eyeball, and we must take care not to cause premature entry or to cause buttonhole of the anterior wall of the sclerocorneal tunnel. This is a side port. Side port is being made with the help of the keratome. We just introduce half of the keratome, and it becomes wound of about 1.8 to 1.9 millimeter. An air bubble is injected, and now this is dye being applied over the anterior capsule, trypan blue dye. The dye is washed out, and now Capsulorhexis is to be done. First, the antechamber is filled up with 2% hydroxypropyl methyl cellulose. Methyl cellulose has been applied over the cornea for better visibility. And now here goes the cystitome. The cystitome has been made by bending a 26 gauge disposable needle. Sclerocorneal flap has been, a capsular tag has been raised. This capsular tag is pulled or pushed, and a rhexis of about 6 mm is made. In SICS, since we have to prolapse the nucleus through the rhexis, we must do a rhexis of about 5.75 to 6 mm. And now the sclerocorneal tunnel is opened. At this time, we must go to the anterior extreme of the sclerocorneal tunnel and then enter into the anterior chamber. We must get a very nice corneal valve for the wound to be self-sealing. Now this is hydrodissection. Though this rhexis was about 6 mm or 5.5 mm, the nucleus didn't come out by hydrodissection. So I am using two hooks. One hook goes behind, the other one rotates the nucleus and it comes out of the capsular bag. Now visco is applied both in front and behind the lens mass. In front to protect the corneal endothelium, and behind to make room for the irrigating vectis to be introduced. Now here goes the irrigating vectis. As the irrigating vectis goes in, the pressure of the irrigating fluid delivers the nucleus through the main wound. The irrigating vectis has been used to deliver most of the epinucleus. Little bit of epinucleus is still remaining. Some portion of it has come out by hydrodissection. And now I am using a 23 gauge Simcoe cannula to remove the cortex. Simcoe cannula can be of 22 or 21 gauge size in SICS. We go through the side port at 9 o'clock and remove all the cortex from all sides. The cortex has been removed, and now in this case a single piece monofocal intraocular lens has been selected for implantation in the capsular bag. Since this is a foldable lens, my plan is to use an injector. The capsular bag as well as the antechamber is filled up with 2% hydroxypropyl methyl cellulose. Now here goes the lens. The leading haptic has gone into the capsular bag. The trailing haptic is dialed into the capsular bag. Now the lens is in the bag, and now visco that has been used for implantation of the intraocular lens is nicely removed. We must not leave any visco in the anterior chamber or behind the intraocular lens, because if we leave visco, there can be raised intraocular pressure in the postoperative period, and the patient may be very much uncomfortable. So we must clean the viscoelastic substance very meticulously. One may think, why I am doing SICS in this case? Yes, I can easily do Phaco in this case, but we have to teach SICS to the beginner surgeons, and this is the surgery that is being done for about 70% Indian population. So this surgery should be done very meticulously. So the visco has been nicely removed. Now this is a bit of moxie, and then the side port is closed by hydrating corneal stroma with BSS. And now conjunctiva is opposed to the limbus by a releasable suture. One can use just a subconjunctival injection of gentamicin and dexamethasone to cause chemosis and the conjunctiva comes forward, or one can use cautery where the conjunctiva gets shrunken and it comes to the limbus. But this is probably the most atraumatic way of opposing the conjunctiva to the limbus. This is a releasable suture, and we can remove this suture after 3 or 4 days. Thank you very much for your attention. Hope this video will help you in learning small incision cataract surgeries.